Okay, well, hello everybody, and a very warm welcome to our online audiences, whether you're on YouTube or Zoom, and whichever part of the world you're in, and whether it's the day for you or the middle of the night. This is the next in our Sussex Development Lecture series on COVID-19 and development, building back better with a question mark. And this is a really exciting one this evening when we're talking about implications for preparedness and response in future pandemics. Not that this pandemic is over. Unfortunately, it's still unfolding in rather dramatic ways in different parts of the world, but it's still a really useful moment for us to take stock of what we're learning through this pandemic and perhaps previous pandemics about the whole approach to responding and indeed preparing for future pandemics. I think what we've already seen with COVID is some limitations of conventional approaches, but also some bright spots for the future of things that really have worked well. And that's what we're going to be talking about today. We're going to be looking at some varied experience of spheres of COVID-19 and what that means for the future. So I'm absolutely delighted to welcome our two speakers. We have Hayley Macgregor, who is an IDS fellow. She co-leads our health and nutrition cluster, and she's also co-leading some really important programs at the moment on pandemic preparedness and response, including our Wellcome Trust Collaborative Award. And she's going to be introducing the topic, and then we'll be in conversation with Sabina Rashid, who I'm delighted to welcome. Sabina is Dean and Professor at the Brac James P. Grant School of Public Health at Brac University in Bangladesh. She's also a long-standing partner in a number of IDS programs. And Sabina, it's really lovely to have you with us today. So just before I hand over to Hayley, a few more practical points. Welcome, as usual, to the amazing Marco Nardi, who will be doing English to British Sign Language interpretation for us during the event. So look out for Marco's actions there. We would warmly invite you to tweet using the hashtags #SussexDev and Global Dev Trends. The lecture will, as usual, be available to watch after the event via the IDS website and YouTube. So please pass on the news if you enjoy it, pass it on to colleagues and friends and your networks. And of course, we'll be very much wanting your questions and comments. So the intro talks will be just about 30 minutes, and then we'll have plenty of time for Q&A and discussion, which you can either type your questions in the chat box in Zoom, or if you're on YouTube, in the comments box, and then we'll address a selection of those in the Q&A. So without further ado, let me hand over to Hayley to introduce our discussion this evening.
Hello, everybody. So this week has marked a year since the stringent lockdown in Wuhan to stem the spread of a novel coronavirus. At the time, we watched in shock from a distance as millions of people had their liberties severely curtailed and the state erected an entire hospital in record time. It thus feels timely in today's lecture to take stock, as Melissa said, and reflect on pandemic preparedness and response. Over the past year, the unfolding of the COVID-19 pandemic has repeatedly shown that what we have witnessed is more than a health crisis. The pandemic has manifested as intersecting crises across areas of health, education, the economy, and social care, as we've indeed heard in earlier lectures. Around the world, we've seen various configurations of public health measures play out in different social, economic, and cultural settings, places characterized also by varied state-citizen relations and levels of trust. And the impacts have been diverse across contexts. Unpredictability and uncertainty are ongoing as new viral variants now emerge with questions about immune evasion, transmissibility, virulence, and so forth. So in this discussion whilst preparing for today, Sabina and I decided to center this lecture on the idea of intersecting crises after Dala, and to ask specifically what this framing of the pandemic might mean for rethinking epidemic preparedness and response now and in the future. and we'll present snapshots of the experiences of COVID from two regions of the world, Sub-Saharan Africa and South Asia. The common point is that we both do research in contexts where the pandemic has catalyzed severe and wide-ranging challenges. In rural and peri-urban Africa and in informal settlements in Bangladesh, there are people living with everyday uncertainties and threats of various kinds in circumstances characterized by precarity, with competing priorities related to climate, conflict, food security, and livelihoods. These acute threats, as well as the slow emergencies, are what people have to navigate alongside COVID-19. And in conclusion, we'll reflect on the challenges that these circumstances then pose for conventional approaches to epidemic preparedness and response. So firstly, what are the features of such standardized approaches? So in recent years, the idea of epidemic preparedness has come to the fore in global health discourse and practice, and has been instantiated in particular strategies and institutional architectures. A reorganization of the WHO strengthened a health emergencies program and laid out a phased response to epidemics in set operational pillars and a cycle for action that inscribes an emergency temporality, and one that would move from preparedness through response to recovery. These plans are situated within a global health security paradigm with exceptional focus on one pathogen. They also privilege planning centrally and central control. Preparedness relies on particular strategies, particularly for prediction, such as surveillance and modeling. There have, of course, been social science critiques of these approaches. For example, Andy Lakoff has characterized preparedness as instilling an anticipatory imagination to respond to future events and prioritize predictive technologies to control outbreaks. Sterling and Schoons have argued that these disease control strategies tend to ignore uncertainties and conceptualize them rather as risks that can be managed. And Andy Sterling gave an excellent account of this in the Sussex Development Lecture in November. There's also been much discussion of the heavy reliance on certain kinds of evidence, such as from epidemiology. There have been calls for greater interdisciplinarity, but also for a plurality of knowledge as relevant, including experiential knowledge of outbreaks. At IDS, we've reflected on our own involvement with WHO and other agencies through the work of the Social Science and Humanitarian Action Platform, in particular how social context as an element to consider in outbreak response can then be instrumentalized through the emergency pillar called risk communication and community engagement. Finally, there's been critique of the way in which top-down and also external action is privileged in response to health crises, such as happened in the West Africa Ebola outbreak. Here, research revealed that people mobilized to protect villages, drawing also on existing experience and adapting to attempt safe burial and care according to ethics of kinship. And such insights from work by colleagues Melissa Leach and Annie Wilkinson sparked our current Wellcome Trust project, and the idea of preparedness from below, exploring how people draw on responses to everyday threats and uncertainties, and what forms of formal and informal public authority are then trusted to act. And I will speak about our findings shortly as I turn now to give you a snapshot of COVID-19 across 2020 in African settings. With the emergence of coronavirus, there were anxious predictions of the devastation that a pandemic could wreak in Africa, given that WHO joint evaluation exercises had consistently assessed all African countries as unprepared, despite health system investment post-Ebola and the establishment of the African Centers for Disease Control in 2017 to strengthen science networks. Epidemiological models predicted many COVID deaths. African countries adopted border control measures early with swift responses whilst cases remained low. In some instances, very stringent lockdowns were implemented early. And what followed, in fact, was a slow and very heterogeneous unfolding of COVID-19, with peaks in a few countries, pockets of infections in others, and some countries spared with very low mortality that seemed verifiable despite very limited levels of testing. And this unfolding picture challenged the notion of a linear temporality and set phases of response. And this early African success has been linked, I'm sure you know, to many factors such as demography and cross-immunity. WHO and Africa CDC have pointed to decisive action and to African leadership and collaboration in joint platforms and to existing experiences of managing infectious disease outbreaks. The lack of recognition of the African success and the predictable reluctance of countries in the global north to look to African experience has been seen as further evidence of the need to decolonize the gaze of global health. Now, since the last quarter of 2020, several countries in Africa have come into the grips of a second wave of COVID, which is, of course, proving much more challenging. There are also some further caveats to
So I think
the socioeconomic impacts of responses have been severe and have intensified inequalities, especially given the high reliance on the informal economy for livelihoods. And I'll give you a picture from two rural field sites in our Welcome project, fieldwork done by Moses Beluku and Fode Kamara in Uganda and Sierra Leone. So for most of 2020, there was actually little experience of COVID-19 as a disease that was seen in either of the villages. It remained a disease of the radio. Ours is Ebola, people said. However, movement restrictions limited access to fields and people could not sell in the markets. Food prices have also risen. In the Ugandan village, farmers resorted to bribing authorities to access their fields to cultivate them. In Sierra Leone, market traders opened the markets on their own authority prior to the government lifting restrictions in June. In Uganda, a resurgence of Ebola in neighboring DRC and severe floods seemed to pose the more imminent threats. Rather than preparedness from below, as analyzed for Ebola, people in both rural field sites were faced with the impacts of public health measures rather than the disease itself. And we've characterized this situation as a negotiation of intersecting precarities. Apart from economic effects, there have also been indirect health impacts. A vertical emphasis on one disease has been detrimental to the treatment for other conditions, to childhood immunization, and indeed sexual and reproductive and mental health, such as actually been highlighted here at Sussex by the Courts Centre. The second caveat in Africa relates to politicization of the pandemic response. And this, of course, has been evident across the world in different forms, not only in Africa. But there have, however, been marked instances on the continent, such as in Uganda, where people in the field site have had to endure a sometimes violent military presence enforcing measures. They've linked COVID restrictions explicitly to government control related to elections and a wider closing of civic space. And thirdly, one cannot ignore the shadow of resource limitations and a lack of capacity for response. And this is particularly evident now in the second wave. In South Africa, the political economy of health, a legacy still of apartheid, is playing out starkly as deaths have surged in the public health sector, related also to a new variant. Across the continent, limitations in testing make it difficult to get a clear picture of the epidemic. As Paul Farmer remarked during Ebola in 2014, no preparedness efforts have any value if one does not have the staff, space, and systems for a meaningful response. So in the grips of a second wave on the continent, the focus has now shifted to vaccine preparedness. The difficulties in vaccine supply to Africa are rightly drawing attention, and comparisons to the delayed access to antiretrovirals at the height of the HIV epidemic. But this also deflects somewhat from many other challenges that a large vaccine rollout is likely to face. So I focused briefly on Africa, but there are, of course, many other examples of success and also multiple failures of response. The trajectory of the epidemic into 2021 is uncertain, but the overall African mortality remains low in terms of its proportion of the global population, officially 88,000 according to the WHO. We're all very aware that this week the UK has reached 100,000 deaths. Indeed, the very countries scoring highly in 2019's Global Health Security Index, the US and the UK, have by most assessments ranked as amongst the most poorly performing. Arguably, the recent focus on the unpredictable behavior of the virus in mutating is creating possibilities for deflecting attention from the politics and assessments of failures, a convenient depoliticization by focusing on the seemingly neutral epidemiology and the hope of a technology providing a complete solution. So in conclusion, what questions arise then for rethinking epidemic preparedness and response? So firstly, questions about the proportionality of public health measures. There have been troubling issues about the balance between health and human rights and economic well-being as well. Secondly, there are also questions about how to achieve context-sensitive responses and how to adapt standard measures. For example, how to account for livelihood realities and incorporate intersectoral thinking, such as for social protection, as part of response. There are also questions about how to foster institutional responses that acknowledge uncertainty and that are adaptive. Fourthly, there are questions about how to support local mobilization and more decentralized responses, both for protection and mitigation of wider impacts. And the point here is not just a romanticization of such efforts, but a recognition of the need to think about governance strategies and resourcing that could enable a better balance with top-down planning. And finally, there are questions about how to strengthen forms of solidarity. We've seen collaboration in science, but globally now there's reluctance to share IP as a global public good, and there's vaccine nationalism. Dr. Tedros, director of the WHO, warned last week that the lack of solidarity for equitable vaccine distribution constitutes a catastrophic moral failure of our time. So in future, the world could respond by only investing in more of the same for preparedness and response, more surveillance and an exclusive focus on technological solutions, rather than balancing these with investment in basic public health systems and addressing entrenched health and structural inequalities, as well as attention to conditions and responses of people and organizations on the ground who might also be facing other crises, both acute and chronic. Fundamentally, we need clear recognition that epidemic preparedness and response are not only technical, but deeply social and political processes. So I'm going to hand over now to Sabina for her analysis of the epidemic in Bangladesh.
Thanks, Hayley. That was really interesting. And I just saw so many similarities as I try and share my screen for the first time in the history of Sabina Rashid. So let me just have a go. Okay. Oh, that's very good. Is that how I do it? Okay. So I'm going to take you through sort of a quick overview of what took place in Bangladesh and where we're at now, and some of my reflections based on all the writings and all the materials available. And there was a lot of reporting in newspapers plus research, and I'm at a School of Public Health. We were undertaking lots of rapid research assessments. So basically it's fault lines in public health in the COVID-19 response, reflections from Bangladesh. I'm a medical anthropologist by training, looking at sort of the critical aspects of medical anthropology, so structural violence and social suffering. So COVID in Bangladesh, from March until January 24th, 2021, what the reported figures are, it's almost 500,000 that have been infected. Reported deaths are around 8,000. Even if we were to add much more to this, it's still much less than what's happening, let's say, in the UK or US. And the interesting thing was we were wholly unprepared, and the country was sort of in some form of a denial. And at that point, there was a lot of news coverage in Italy, what was going on, and WHO declared it as a global pandemic. And suddenly the government declared a shutdown from March 26th onwards. I remember, I was teaching and we were given 2 days, and it was declared officially as a holiday because the government didn't want the country or the communities and the population to panic. So some of the measures that were kind of declared as the holiday was, initially they declared a 10-day holiday, and then it kept getting extended to another 10 days, another 10 days, and it continued till almost end of May, around June. And immediately they kind of set up a huge surveillance system with army and police throughout the country to ensure lockdown. So everything was locked down. I mean, it was just sort of the entire city, the country there was no one there. No one was allowed to go on the streets. They shut down businesses, factories. They were slightly undecided, but it was still shut. Educational shut, transportation, shopping areas. Officially, they said no meeting in mosques and other places of worship. The holiday kind of notion, and in the history of Bangladesh, there's never been a shutdown. I mean, we've experienced liberation war, we've experienced other forms of crisis, but the entire country has not been shut down. One of the criticisms was that we'd adopted a model from the West, but we don't have that level of social safety net or economic sort of growth or support structures, infrastructure, in terms of meeting the needs of much more sort of the larger population. 85%, they say, of the informal sector, informal workers have been affected by the COVID pandemic. Anyways, there was lots of large incentives to revamp the economy, roll out of packages, relief materials, but there's also a lot of criticism about mismanagement, the distribution, fair distribution, and whether in fact it was trickling down to everybody else. And there was a level of politicization in terms of political groups were favored at the grassroots level. Economists say around 20 million people have already been, this was in April 2020. Other news reports indicate that because of the COVID pandemic, there's already 30 million in poverty, which will probably rise to about 50 million. Around the same time, you can see the interconnectedness between the global and local sort of worlds. I mean, Hayley alluded to in terms of vaccines and social justice, or justice basically. Here, many buyers canceled orders even after they'd ordered it and they were made. And the BGMA, which is the Bangladesh Garment sort of Manufacturing Association, reported sort of canceled orders up to almost 3 billion. So during this time, there was a lot of research undertaken by many institutions, to name a few: Brac University, the school, BIGD, there was CPD, there was many institutions, PPRC, Brac, and Dhaka University. And what they found was there was a lot of panic. Food consumption had reduced. Many people had no sources of income because they couldn't work anymore. Jobs were shut or they were losing their jobs. Increased emotional stress, mental stress. There was also, during the peak of the pandemic, as we call it, the peak, the shutdown, March, April, May, lots of stigma around COVID, misinformation, fears, rumors. And this was across actually all social classes. So I'd hear about suburbs in well-to-do areas where they'd put a lock outside the gate if anyone was rumored to have COVID. Doctors were being evicted from apartments. In informal settlements where we were doing research, families were kicked out because they had returning sort of migrants who'd come back from Italy. And there was this whole fear about these migrants from television coming from Italy and China who were carriers of the virus. At the same time, in our national television, there was a lot of fears because there was a lot of stories and pictures of hospitals turning patients away, people dying. And there was also a very biomedical approach to managing the shutdown. And then you have to see that everyone almost has a phone. So a lot of the preferred source of information, because you had a clinical task force set up, so a lot of the sources of information was social media and lots of misinformed platforms where there were beliefs like if you prayed or went to mosques or you did other home care practices, you'd be fine from COVID. So some of the arguments they say is that during the time of the peak of the pandemic, the response was really reactive. It was waiting, and then making decisions. The initiative, some of the criticism has been that it's been very disjointed, a lot of indecisiveness, confusion. We'd hear that there would be phase-by-phase lockdown. Then we'd hear that there'd be full-scale lockdown. Then we'd hear garment factories are opening. No, they will not open. At some point during the peak of the pandemic, there was a huge religious gathering that was allowed for some religious, imam who passed away. Our health systems was woefully unprepared. And the clinician task force set up by the government in March 2020 did not include any of the stakeholders. It didn't include NGO actors. It didn't include the private sector. It didn't include social scientists. It did not include civil society. It was really a national coordination committee and a technical committee in the health services ministry, whereas the challenges were beyond health. It was economic mortalities with health and other sorts of social kind of disruptions going on. Another critical situation was missing data sources. The Bangladesh Bureau of Statistics was criticized for being completely silent around this time, their inability to share data. IEDCR, which is a wing of the government, was their data and sources, given the low testing, was met with skepticism. And during this period, there was a law passed to monitor reporting on the COVID-19 crisis. And there were some reported arrests in May. So there was sort of fear mongering. At the same time, the newspapers were actually quite vocal in terms of printing a lot of discussions around how to manage COVID. So concepts of risk and public health problematic. I mean, just draw on Hayley's point that the whole clinician task force looked at, masks, hand washing, and lockdown. But that really makes it an individual determinant of health, and it's very biomedical in focus. Whereas for most of the ones who are vulnerable, it's not just health, it's economic mortalities that was feared, hunger was feared, a lack of jobs and loans and disruptive social networks, which was huge in many families as they continue to face this problem, was a big problem. So context matter, and one of my arguments is we need to reframe health beyond a biomedical disease model approach. And it has to have sort of a socially just model, because we have to engage with communities at the center. When we learn about pandemics, when we learn about responses, and it must be balanced with social and economic interventions. And if we expand the notion of risk, I think it's very important to think about vulnerabilities, because communities are very diverse. And they're socially, structurally, biologically, demographically, and many different ways affected by COVID or by these sorts of what I would call as a humanitarian crisis. Another challenge in the world of public health is there's a hierarchy of data. So what counts as data is usually the numbers. And I think it's really important to reflect that pandemics like this, or even crisis in the past in Bangladesh, the role of social science, to really look at the nuanced and realistic perspectives of those who are most vulnerable and affected by the pandemic in terms of responses. So several initiatives were taken in 2020, despite that there was a lot written up on the government not being inclusive enough. NGOs, 212 network of NGOs started providing assistance in 49 of the 64 districts, creating awareness, food, health materials, and cash. Brac, which is one of the largest NGOs, launched community health workers to deploy messages and referrals, started making reusable masks through their handicraft stores. They started setting up hotspots with hand washing stations, campaigns in transportation areas in partnership with city corporations. Leaflets were distributed, stickers were distributed. Private sector started donating funding to government, to other partners, setting up hospitals. Bangladesh Health Watch, which is a health working group, a citizens platform hosted at the school, launched a series of research on PPE, the dangers of having poor quality PPE for frontline workers. They also talked about the model of complete shutdown that would affect economically other districts in the country that were not as hard hit as Dhaka and Naranganj. Many citizens, many philanthropists started distributing food and relief materials, and I've just listed a few. So just to kind of wrap up, reflections, and is it a step in the right direction? I think so. If you look at the history of Bangladesh, we had a very sort of, a liberation war, and one of the successful models of Bangladesh has been its sort of very much a participation of citizens approach, which is an inclusive approach where you take everyone from communities to work together. And we've done it through floods, droughts, cyclones, and that has been the common success factor. And what this inclusive and locally led committees at the community level with government backing can do is that community members are trusted by other community members rather than external forces. And in the past, mobilization was women, men, local government, informal providers, mosques, temples, schools, practitioners, informal providers, medical community, NGOs, media, journalists, and teachers. So one of the recommendations is, how do we have a more inclusive approach as we move forward? Because it has worked in the past for our ORS in dealing with diarrheal diseases and death rates, in dealing with TB, tuberculosis, and dealing with immunization, which was 20% to 80%, for family planning, with the door-to-door approach where we had fertility rates of 7 to now it's 2.1. So one good thing was in December 2020, a platform with NGOs and other actors coordinated by the government has been set up to review what can be done as the crisis unfolds in the country in terms of the health sector, in terms of health systems, in terms of like dealing with COVID and the economic sector. Another recommendation that's come up more recently in an article written by Mushtaq Chaudhry, who's ex-vice chair of Brac, was, and by Fawzia Rashid, one of the Brac sort of board members, said, you know, we need to actively roll out what we have, which is health workers. We are very well known in terms of best practices around community health workers. And the community health worker model in Bangladesh has been exported to other countries, including Afghanistan, Liberia, South Sudan, and Uganda. And we have about 130,000 community health workers. We could start with that. They can prevent infection. They're a trusted source of support. They're really a bridge to very vulnerable communities. While Bangladesh has not, COVID has not been the greatest crisis in our history, we face other forms of crisis. And the Bloomberg report recently included us in the League of 20 most resilient nations. Despite the modeling estimates and the predictions that more than 500,000 would die. I want to use the quote by Chaudhry, who said, given the resilience of the people, perhaps we could do better and keep improving if policies were adopted and implemented well, with a much more of an inclusive approach, using communities, using a bottom-up approach as we move forward. So just finally, my main points are we really need to reframe public health from a biomedical model to a larger, sort of more holistic approach, which allows for the social justice and rights component. Vaccines are useful, but they're not a magic bullet. And I think it's now a critical time more than ever to look at the existing inequalities that have always been there. It's just that COVID has kind of opened that. It's magnified what has always been there, the poverty, the inequalities, the inequities. And I think it's timely now to engage with government, with actors globally, nationally, locally, with development partners to unpack what we want to do if we really want to achieve SDGs, and really critically understand that some of the discourses that exist sometimes are much more harmful than helpful. Thank you very much.
Thank you so much, Sabina and Hayley. If you all put your cameras on again, I think those were fantastic presentations, both of them. And I'm just struck by some of the real parallels between them. I mean, we've heard from both of you that epidemics are social and political as much as, or probably more than, they're technical. We've got two very different big contexts here, but nevertheless in both, this is not the worst crisis that there's been. And indeed, I think one of the quite interesting emergent narratives, certainly in the African context, is that somehow African countries were better prepared because they had had previous exposure to epidemics. Certainly the cases made around Ebola. And of course, now we've heard from Bangladesh. Bangladesh had had plenty of practice in dealing with floods and with climate change and other related problems. I think we've heard from both of you that this is not just a health crisis, and actually in many ways, vulnerability was as much or more to the effects of a fairly insensitive top-down public health response and the other health and well-being and social and economic precarities that intersected with and in some cases deepened. And I think we've heard from both of you about the value of thinking harder about the bottom up, whether it's community health workers in Bangladesh and models of inclusive participatory approaches, or in some of the African contexts in very diverse ways, some of the solidarities people have created locally to cope with sometimes these top-down public health measures in order to keep livelihoods going, to negotiate these intersecting precarities, as Hayley put it. So really lots to think about there, which is very different from the standard technology plus top-down state and internationally led response that has been the standard and is being the standard now. So let's open up to some questions, and please keep them coming. Add them to the chat and to the comments box. But let's start with a few, and I'll perhaps read out a selection and then ask Hayley and Sabina to respond to the ones that are relevant, and then we'll take another round. So we've got a big question here from Mohammed Rasul Qaida, who asks, why is it that developed countries like the US and the UK are grappling and often failing with COVID-19, whereas other conventionally lower middle income countries like African countries, Vietnam, Southeast Asia are managing it rather better? And it would be great to have your comments, I think, on that one. Somebody else then anonymously has asked whether the low rates of COVID and COVID-related deaths across African countries might just be put down to a lack of testing. And it would be good to have a comment on that, and perhaps also in the Bangladesh context as well, where the levels are relatively low compared with certainly the US and Europe. And then there's couple of more specific questions about Uganda that Hayley, you might be able to respond to, or you might want to think about in relation to our Ugandan researchers. So Nick James is asking if you could say a little bit more about how long the formal weekly markets were actually closed in Uganda, and how that was actually reconciled, I suppose, politically with people's need for food and their access to fields. And what are some of the legacies of that lockdown and that suffering in terms perhaps of people's worries about a second wave. And then finally for this round, I think we've got a point from Shandana, who says she really likes the point about preparedness from below, especially in terms of the interaction it requires between local governance and public health. And perhaps both of you could say a little bit more about what that might mean, and so Bangladesh as well as Africa, on the most effective modalities for strengthening the responsiveness of perhaps local state institutions to support local communities. So how do you kind of link up the top down and the bottom up, and what's the role of local state institutions in that? So that's a sort of bunch of questions. Maybe Hayley, would you like to pick up on some of those first, and then I'll come to Sabina.
So the first question is I guess the big question that all these analyses and evaluations are facing, and it's not a simple and easy answer, Mohammed, as I'm sure you're very aware, and there have been these marked successes, and I mean the African picture is very mixed. There's certainly these narratives of success, but they also contexts where health systems are really currently being overwhelmed. So some caveats there, as I said, but just to name a few, and I'm sure you're aware, I mean there are lots of analyses around different diversity epidemiologically of the epidemic related to factors such as demography, housing, and comorbidities in the population which relate to health inequalities often. Then I guess a whole set of analyses, thinking particularly related to Asia, which I'm less familiar with that context, but I'm sure you know a lot of people looking at, for example, the sort of very effective public health systems around track and trace, the use of digital means to do that, the experience of SARS. There's a whole line of inquiry there that I'm sure people are quite familiar with. And then I guess there's another whole area, which I know colleagues at IDS are doing work on, are probably better qualified to speak to than me, but even as someone who works in health, there are clearly questions around state competencies, but also different political systems and different levels of trust in government. And we've seen that in the UK, the sort of effect of that, the nature of action. Is it decisive? Is it trusted? What is the nature of communication with populations? Do populations trust the decisions the government makes? And then I guess a whole set of questions which Sabina surfaced about how government works with other partners, and again, whether there's trust there, how you can achieve these more decentralized responses and support those and really harness local mobilization. So that's not a very systematic answer, but I mean, I'm sure you're all aware these are the kinds of issues currently being talked about, and of course questions around health system capacity, of course, also fundamental there. To go to the question about rural Uganda, I mean, I think this is this relates also to the question about how one knows the picture in Africa, and the question about testing. And of course, particularly during that first wave, which peaked in the sort of 4 main countries in July and August, there were a lot of questions about the figures. And of course, it was very evident that there was a lack of testing. But I mean, a lot of people looked at this, and I mean, even though there's very poor death registration in some contexts, the general assessment is that there wasn't some overwhelming mortality that went unrecognized, although undoubtedly the mortality is greater than was recorded. And I can speak certainly to the South African situation, which I probably know best, and the Medical Research Council has consistently produced reports of excess mortality, which is usually doubles the death rate. So there is an awareness that there's been a lack of recording, but and certainly now it's making it very difficult to know what's going on in the second wave. But I personally am not of the view that there's been an overwhelming, in the first wave there was an overwhelming set of infections and mortality that was completely undetected. In terms of rural Uganda, and in particularly food and this point about hunger and farmers, I think the issue of food security and the epidemic, I mean, others again have worked on this at IDS, but it's a huge issue. And the markets in this particular rural area, the first nationally recognized death in Uganda was only in July, and things did ease around July, August. And the issue with getting to people's fields in that particular district also related to the fact that that area is on the border with the Democratic Republic of Congo, and it's an area where there's been Ebola, and there were restrictions about crossing to fields across the border. And there was a lot of unhappiness and hunger in this particular area. Although there was a militarization of the response, there was also people started negotiating with soldiers, so that eased the kind of restrictions around accessing their fields. What was a problem was the rising food prices, and people complained about that as well in Sierra Leone. So malnutrition is going to really be one of the sort of legacies, one of the secondary health impacts, and indeed in some countries, the end of school feeding schemes because of closures of schools and so forth. So that's a really big topic, and one that the particular person is right to question about. And then finally, I think that Sabina gave a really, really interesting reflections about that relationship between state institutions and other forms of response, and this idea of a more inclusive way. And I think that's a really important question for research. Sabina and I are both part of a GCRF hub called Arise, and there's a lot of tension at the moment to governance structures, forms of accountability, and how to really get a better relationship, not a binary between top down and bottom up, but a better coordination. But of course, this is really difficult in contexts like Uganda, where there's been marked politicization of the response. But I think, let me hand over to Sabina.
Yeah, right.
So thank you, Hayley. That really helps when you go first, because I can just say, yeah, I agree with Hayley. And if In Bangladesh, what's interesting is that we have a particular history, a socio-cultural, political, economic history. You know, we were suddenly liberated. I mean, we fought a war of liberation with Pakistan. The society had to come together because many intellectuals were killed. We lost, you know, many intellectuals at different levels, academics to people in the army, and the community just kind of came together at different levels. And it's always had that approach with family planning right at the beginning, with immunization, with setting up structures, because there was so little there. This whole, the puzzle of Bangladesh, or they say South Asia, at least they say for Pakistan and Bangladesh, because I was talking to doctors in Bangladesh and researchers and doctors in Pakistan. There was an online Zoom call because the dreaded numbers from, you know, Imperial and Johns Hopkins of 500,000 are going to die, 700,000 per day, blah, blah, which thank God it didn't happen because, you know, we are a low resource country with, you know, very weak health systems. And it's a puzzle. I don't think there's any straightforward answers, but what they would say is that, look, we have TB vaccinations. Most of a larger population are 85% are poor. They're outside getting the sun. We don't take flu vaccine shots. They are immune, general immunity, because there's so many other forms of diseases and illnesses that are constantly dealing with. Maybe the type of virus in the South Asia context is a different variant. I'm not a doctor, so this is what I was asking. And we have a much smaller elderly population. It's a much younger population. So all of these factors maybe have come together. And yes, testing is low, but I would agree with Hayley, because there's journalists everywhere to report deaths and to say, you know, the government's covering up. And it isn't that level of mortalities, even if it's not COVID. So the reality is that we haven't had that kind of shock, but the economic shocks and the continued vulnerability, additional vulnerability of groups and sort of groups that were slightly getting better and who are now having to go back to debt and, you know, no jobs or worrying about income or dropouts from school because they now have to, you know, support the family. Those sorts of sort of unintended or intended consequences we will see for a long time coming. And I think, I can't remember all the questions, Melissa, but just to say that one of the most important things I see is that communities, I saw this in the slums because they're very congested. They can't afford soaps. They can't, you know, there isn't water sources everywhere. It's not like they can buy masks, so they'd share a mask. They'd use a piece of cloth. The reality was, they said, you know, we can't manage this. Are we going to eat? Are we going to look for a job? Are we going to follow these guidelines that don't work for us? And I think as we move forward, there will be more epidemics or pandemics. And I really think we need to go to the roots of what are the causes of some of this. Because until and unless we address this, I feel like it's a cycle. This is the first big shock for many of us, at least what I've seen. You know, people keep referring to the Spanish flu, but I think there's going to be more. And unless we actually have some really critical conversations and an openness to learning from developing countries of also what's working and what's not, and changing some of the discourse and the language, even in public health and development, which is quite top down, we're going to be in a sort of a deja vu. That's my fear. Anyways, thank you.
Those are really great points, and we've probably got time for one more quick round. And actually the last comment from Sabina here very much leads into the other set of questions that I wonder if we could talk a little bit more about. So I think you've both presented a lot of learning and positive experience in Bangladesh and in a number of African countries. So, and the question really is, why is it that the US and the UK hasn't learned from these, and how could it do so better? So just to put it in the words of the questioners, Cesar Geronimo Asquinza has said, the experience of Bangladesh offered evidence on the need for multi-systemic approaches to address disasters and for community-based engagement. And he goes on to say, those are schools of thought that are now really strongly acknowledged in the development and humanitarian world, but they haven't filtered to the rest of the stakeholders, particularly in the so-called global north. And then Lila, who makes some positive comments again about the things you've said, asks, how can Europe and the USA learn more from these bottom-up approaches and solidarities that both of you have spoken so eloquently about? So I wonder if you could comment a little bit on that. I mean, one doesn't want to paint a rosy picture of everything having been fine in the context you've been talking about, but nevertheless, there is something about the inability of that flow of learning to run the other way, which I think is worth thinking about in the context of a world where we're trying to see development as something, as progressive change for everyone everywhere, as universal, and trying to work in a slightly more decolonized way. What do these experiences tell us? And there's one more question that I wonder if you might just address in passing. So Lillian Mbegbu has asked, what is the role of the media? She says in the growing cases of COVID, but also asks, how would you suggest the media play a more prominent role? So perhaps you could also just reflect in finishing on perhaps the roles for the media, but also for different types of evidence, because one of the points you both made is that there's a problem in narrow biomedical or epidemiological views of COVID. And you both, I think, made the case for an expanded set of knowledges and forms of communication, including from the social and the political worlds. So perhaps you could reflect a little bit as well on what it would take for that to happen. So big questions. We've got about 8 minutes left. So if you could sort of take a couple of minutes each.
Okay.
Can go in the other direction. Sabina, if you want to go first.
Yeah, sure. You know, I think it's a very complex sort of embedded sense of superiority and a hierarchy of knowledge. Who are the knowledge bearers? Who know what is best? How is even development, the language of development and progress framed, right? There's poorer countries, there's rich developed countries. We have technology. I'm putting it very simplistically, but even if you look at the language in literature, in the way development funding is organized, it's the way the ecosystem of development of global bodies, national bodies. Who do we refer to as global? Who do we refer to as national? Who do we automatically see as experts? There's a kind of implicit assumption on who are the leaders and we're kind of all catching up, right? So the pandemic kind of shocked people. I'll give you two quick examples. One was I got a phone call from some colleagues I was talking to in the West. And they said, I don't understand. How come you're okay in Bangladesh? I mean, we're having such a hard time. How can Bangladesh be okay? Because there's assumptions around we represent floods, famine, disease, death, right? That's sort of the image of developing countries and our inability to cope. And aid is sort of one way, and we get support and help from this sort of, I'm putting it very crudely, right? Then you have the other component where we were writing an article on the pandemic, and they wanted case studies from Bangladesh and Kenya to show the problem of COVID. So I talked to my colleagues who are authors, and I said, well, I think it should be case studies from the US and Italy that should be there so that we can understand what worked well in Vietnam and what worked well in, you know, certain countries in Africa or even in Pakistan. And that led to some sort of a lot of sort of genuine, I think there was sort of a kind of a silence. And I think sometimes many things that we take for granted in terms of knowledge, we haven't actually unpacked where that thinking comes from. We know where it comes from. I think the pandemic will allow us, or we should push that, to say, what can we learn and why should we be open to learning from countries that we see differently or as incapable of being as developed as other countries. So it's really unpacking notions of development and progress, but also who has authority and who decides and who are the knowledge bearers, right? I mean, that would be my sort of take on it.
Yeah.
Very crudely. Yeah. Thank you.
Fantastic. I think fundamental rethinkings of development and of the hierarchies that have dominated the field. So Hayley, over to you, and also for any final comments, because we're moving towards the end now and slightly running out of time.
Yeah, well, it's hard. That was very eloquently and powerfully put, Sabina, so I can't top that. But just to talk to Africa, I mean, I think, with outbreaks like Ebola, there's always been this out of Africa narrative of the epidemic, and this really shifted that, and shifted this idea of external intervention needing to save Africa, although of course that will persist for a long time in global health. So, maybe it is going to help just to shift a little bit in that sort of very biomedical, quite colonial practice of global health. I think in Africa, I mean, certainly there was also the Africa CDC, and this was sort of the moment of the Africa CDC, and someone like John Macgregor, the director, very impressive in the sort of swift action again, forming collaborative platforms and really drawing on this past experience. So, for example, in South Africa, the epidemic of HIV, I mean, I was a doctor in that epidemic, and those 2 decades of community health workers testing, tracing for TB, all of that sort of came to the fore. And indeed, in sort of non-health networks, such as in Kenya, Sabina mentioned, I mean, some of the most impressive examples of really mitigating the effects, for example, of hunger, came from Slum and Shack Dwellers International, SDI, and their existing networks in informal settlements in Nairobi, working with the Nairobi municipality, for example, to identify the most vulnerable and orchestrate appropriate shielding in those contexts. So again, the ability to sort of recognize context-sensitive approaches, and just to contrast that with the UK, where we've seen a very, as you all know, very central government control of things like test and trace, sort of absence of really drawing until quite late on local public health knowledge and expertise, sort of a lack of trust of more decentralized approaches. But even here, I think we saw people responding. We saw solidarities, particularly in the first lockdown, and people responded to take action even before the government did, because the government action was late. So I think we've seen these examples everywhere, but they've been marked examples in Africa that really do need to be lifted out and examined, and this inequality of flow of learning really does need to be challenged now. At the same time as the sort of narrative of African success also needs to be nuanced, so that we can also examine some of the real difficulties, such as the sort of fact that, as John Macgregor himself has said, we need much more proactive approaches next time rather than reactive. There really does need to be health systems strengthening, and indeed also strengthening of laboratory capacity. So it's both. And the role of the media, that's a complex question. I think what I will say in terms of also the question about social science knowledge, I think it's very interesting in our involvement with WHO, there's still quite limited approaches to what's called risk communication and community engagement, and this idea of needing to sort of give people information that so-called communities are homogeneous, that they are ignorant of biomedical knowledge, and that they sort of drive infection, then they need to be educated. And I think what's really emerging now, which is another experience of this epidemic, is the need for dialogue, of recognizing the capacities there, of trying to understand the challenges people face, including how they have to navigate these competing priorities. So that would be my final word.
Okay. Well, thank you both so much. And I think those were fantastic responses. There's a lot of other questioning going on in the chat, which we haven't had time for. But I'd really like to thank you both, and also to thank, as you are doing, the projects that have contributed to what you've said today and are continuing to do ongoing work with vulnerable populations in these countries. So the Pandemic Preparedness Project by the Wellcome Trust, the Arise project that's helped to support Sabina's work is looking particularly at low-income settlements, and others. So these are all very much collective efforts, and they are very much ones that I think, as you've clearly shown us, have the potential and really need to create some reversals in the ways pandemic preparedness and response happens, in the ways that health problems and epidemics are conceived of, beyond the biomedical to being much broader, to embrace the local and the bottom up as well as the top down, and perhaps quite fundamentally to reverse some of the lines of learning that have dominated development, because we're seeing here some real positives and some really exciting, historically embedded ways of doing preparedness and response very differently, in ways that are more community engaged, more inclusive, working in different ways between citizens and state, in ways that are fostering and building on legacies of trust, even sometimes in situations which are quite polarized, as they have been in the UK and the US, but are also arguably in Bangladesh and some of the African contexts. So lots more that one could discuss, but I think you've both given us fantastic food for thought, and actually some really important messages today that we can all take forward and that the world needs to hear. So just to remind everybody, if you came in late, or share with your friends, this has been recorded. So people are asking about that. The link is on the IDS website for the YouTube recording. Please join us for the next in this SDL series, which will be on the 11th of February, on migration issues, invisible, othered and exploited, particularly focusing on India, where we'll be hearing from Priya Dashinka in conversation with Mukta Naik. Looks as if that'll be another really exciting one. Thanks once again to Hayley and Sabina. That's been brilliant. And have a good rest of the day or the night, wherever you are. Stay safe and take care.
Stay safe. Bye-bye. Thank you.
Bye-bye.
Thank you.